Welcome back to the teaching service. Today we work through chronic diarrhea, defined as diarrhea lasting more than 4 weeks. It is a complaint that can feel bottomless. The differential is enormous, but there is a clean way through it. We will follow one patient from her first clinic visit all the way to her final diagnosis. And along the way we will build the single most useful tool in this topic, the stool osmotic gap. By the end, you will be able to sort any chronic diarrhea into a category and know exactly which test to send next. Let us meet the patient. This lecture is built for residents at every level. We start from the fundamentals and still reach guideline level detail. Here is our patient. A 54-year-old woman comes to clinic with 5 months of diarrhea. She describes 6 to 8 watery, non-bloody stools a day. The one detail that should already grab you is this: the diarrhea wakes her from sleep. Nocturnal diarrhea is a red flag. It points toward an organic cause and away from irritable bowel syndrome. She has also lost 12 pounds without trying. Weight loss is the second red flag. So before we have a single laboratory value, this is an organic problem until proven otherwise. Let us take a full history. Notice what we already have from one sentence: a chronic timeline, a nocturnal pattern, and involuntary weight loss. 3 findings, and all 3 point the same direction. Here is what we want you to walk away with. First, define chronic diarrhea and sort it into its 4 categories. Second, calculate and interpret the stool osmotic gap. This is the spine of the whole topic. Third, move through the workup algorithm branch by branch. Fourth, recognize the watery causes, osmotic and secretory. Fifth, recognize the fatty causes, malabsorption and maldigestion. Sixth, recognize inflammatory diarrhea and its markers. Seventh, spot the history and examination red flags. And finally, match your treatment to the mechanism you found. Keep the algorithm in mind throughout. Every one of these objectives hangs off it. If you only remember one thing today, make it the gap. Let us fill in the history. The stools are watery and non-bloody. There is crampy lower abdominal pain that eases after she goes. The diarrhea does not spare her at night. She is up 2 or 3 times. She has tried skipping meals on bad days, and it makes almost no difference. Hold on to that detail. Whether diarrhea improves with fasting is a genuine diagnostic test. She reports no fever, no blood in the stool, no recent travel, no antibiotics, and no sick contacts. She has not changed her diet and does not chew sugar-free gum. One more negative worth stating: she has taken no antibiotics, so this is not a post-antibiotic diarrhea, and it is not likely to be Clostridioides difficile. Now the history that changes the differential. She has Hashimoto thyroiditis, an autoimmune condition, and her mother has autoimmune thyroid disease as well. Her medications are omeprazole for reflux, sertraline for depression, and naproxen a few times a week for her knees. Write those 3 down. They will matter enormously later. She has had no abdominal surgery, no bowel resection, and no radiation. She drinks little alcohol, does not smoke, and takes no laxatives or herbal supplements. So autoimmunity and medications are our 2 strongest threads. And notice what is absent. No bowel resection means bile acid diarrhea is unlikely. No radiation means radiation enteritis is off the list. On examination, she looks well but thinner. Her body mass index is 22, down from 24 last year. Vital signs are normal. Mucous membranes are slightly dry. There is no rash, no mouth ulcers, and no joint swelling. The abdomen is soft with mild diffuse tenderness. No mass, no organ enlargement, and importantly, no surgical scars. Rectal examination shows normal tone, and brown stool that is negative for occult blood. A normal examination does not reassure you here. In chronic diarrhea, the examination mostly rules things out. The work is in the categories. 1. Deliberate finding: the absence of surgical scars. In chronic diarrhea, an unremembered bowel resection is a real trap. So look, let us define the term precisely. Chronic diarrhea means loose or watery stools lasting more than 4 weeks. That 4-week line matters. Under 4 weeks, you are mostly thinking infection. Past 4 weeks, infection becomes much less likely, and the differential shifts to chronic disease. Diarrhea itself means increased stool water, which shows up as increased frequency, looser consistency, or greater stool weight. Frequency alone is not diarrhea. A patient with formed stools 3 times a day does not have diarrhea. So anchor on stool water and on the 4-week clock. One more practical point: always separate diarrhea from fecal incontinence and from overflow around constipation. Patients use the same word for all 3. Here is the framework that makes this topic manageable. Every chronic diarrhea falls into one of 4 buckets. First, watery, which splits into osmotic and secretory. Second, fatty, which splits into malabsorption and maldigestion. Third, inflammatory. Fourth, functional or structural. Almost everything you will ever be asked about lives in one of those 4 boxes. Your job at the first visit is not to name the disease, it is to name the bucket. Once you know the bucket, the test list becomes short, and the differential becomes finite. So bucket first, diagnosis second, and know that the buckets overlap. Celiac disease raises fecal fat and the osmotic gap at the same time, so read the whole picture. Before we talk about disease, look at the normal numbers. About 9 liters of fluid reach the small intestine each day, roughly 2 from what you drink, and 7 from saliva, stomach, bile, pancreas, and intestinal secretions. The small bowel absorbs about 8 of those 9 liters. The colon receives around 1 liter and absorbs nearly all of it. What is left in stool is only about 100 milliliters of water a day. Now notice the margin. The colon can absorb several extra liters if it has to. So diarrhea means either an enormous solute load or the absorbing machinery itself has failed. Put another way, the colon has a very large reserve, which is why it takes a real disease process to overwhelm it and produce chronic diarrhea. Now the mechanism, and there are only 2 ways to get watery stool. On the left is osmotic diarrhea. A solute sits in the lumen that the gut cannot absorb. It holds water osmotically. Water follows it into the colon and out of the body. Take the solute away, and the diarrhea stops. That is why osmotic diarrhea improves with fasting. On the right is secretory diarrhea. Here the epithelium actively pumps anions, mostly chloride, into the lumen, or sodium absorption is blocked. Water follows the electrolytes. Nothing in the diet drives it, so fasting changes nothing, and it continues at night. One practical consequence: asking the patient what happens when they do not eat is essentially a bedside version of the stool osmotic gap. Let us formalize the history. Ask about timing, how often, and whether the diarrhea relates to meals. Ask specifically about nocturnal diarrhea, which associates with organic causes like inflammatory bowel disease rather than irritable bowel syndrome. Ask about abdominal pain and weight loss. Ask about prior surgery, particularly bowel resection, and about chemotherapy or radiation. Ask about diet, including caffeine and poorly absorbed carbohydrates and sugars. Ask about infectious symptoms, immunocompromise, and travel. And always ask about laxative use and about stress. And ask about the stool itself: watery, fatty and floating, or bloody. The answer already assigns the patient to a category. Now the medication list, and please do this every single time. The classic offenders are reperton pump inhibitors and histamine 2 receptor blockers, antibiotics, colchicine, selective serotonin reuptake inhibitors, angiotensin receptor blockers, non-steroidal anti-inflammatory drugs, chemotherapy, and caffeine. Now look back at our patient. She takes omeprazole, a proton pump inhibitor, sertraline, a serotonin reuptake inhibitor, and naproxen, a non-steroidal. She is on 3 drugs from that list at the same time. A careful medication review is one of the highest yield things you will do. And ask about over-the-counter products too. Magnesium-containing antacids and sugar-free products never make it onto the medication list. The physical examination is focused: general appearance and body mass index, signs of systemic disease, surgical scars, and rectal tone on digital examination. The first laboratory panel is the same for everyone: a complete blood count, a metabolic profile, albumin, thyroid-stimulating hormone, iron studies, and fecal calprotectin. After that, the testing becomes category-specific. For imaging and endoscopy, colonoscopy is usually warranted for chronic diarrhea of unknown cause, and abdominal computed tomography or magnetic resonance imaging is warranted if you suspect a systemic problem. A word on fecal calprotectin: it marks mucosal inflammation, and it is most useful when normal, arguing strongly against inflammatory bowel disease. This is the algorithm for the workup of chronic diarrhea, and it is worth memorizing. Start at the top with the patient in front of you. The trunk runs straight down the middle. As you descend, you can be pulled off onto 2 side branches. The first branch asks about fecal fat. The second branch asks about inflammatory markers. If neither branch pulls the patient off, you land on the stool osmotic gap at the bottom of the trunk, and the gap splits the watery diarrheas in 2. Notice the design. It is a series of yes or no gates. We will now walk each gate one at a time. One more thing to notice: the branches are not sequential in time. You usually send the stool studies together and let the results tell you which branch the patient belongs on. First gate: fecal fat. If the stool is positive for fat, the patient steps off the trunk into malabsorption or maldigestion. Clinically, these are the fatty diarrheas: bulky, foul-smelling, floating stools. From there, the next tests are chosen by history. Check tissue transglutaminase antibodies for celiac disease. Check stool elastase for pancreatic insufficiency. Use carbon-14 xylose and hydrogen breath testing for bacterial overgrowth. And go to upper endoscopy with biopsy, or endoscopic ultrasound, when you need tissue or pancreatic imaging. Our patient's fecal fat was negative, so she stays on the trunk. Remember the pairing. Malabsorption means the mucosa cannot take nutrients up. Maldigestion means they were never broken down. Second gate: inflammatory markers. If the stool is positive for occult blood, or positive for white blood cells, or positive for calprotectin or lactoferrin, the patient steps off the trunk to the left into inflammatory diarrhea. These markers tell you the mucosa is damaged and inflamed. The next two steps are stool cultures, to look for a treatable infection, and colonoscopy, to look at and biopsy the mucosa. Our patient's occult blood was negative, and her fecal calprotectin was normal, so inflammatory disease is unlikely. She stays on the trunk, which brings us to the osmotic gap. And remember that a positive marker does not name a disease, it only names the branch. You still need cultures and biopsies to say what it is. Here is the formula, and this is the heart of the topic. The stool osmotic gap equals stool osmolality, which we assume is 290, minus 2 times the sum of stool sodium plus stool potassium. Two questions come up every time. Why 290? Because stool equilibrates with serum, so we assume the serum value rather than measuring it. Why multiply by 2? Because every sodium and potassium ion is matched by an anion, usually chloride or bicarbonate, so doubling accounts for those unmeasured anions. What is left over is the gap, the osmolality that electrolytes cannot explain. And one caution, the stool sample has to be liquid. You cannot get a meaningful osmotic gap from a formed stool. Now the split. If the gap is less than 100, electrolytes account for nearly all of the stool osmolality. The stool is essentially secreted electrolyte solution. That is secretory or functional diarrhea. And the next steps are a computed tomography scan, colonoscopy, and hormone levels. If the gap is at or above 100, something other than electrolytes is holding the water, an unabsorbed solute. That is osmotic diarrhea. And the next steps are a hydrogen breath test, an empiric lactose-free diet, and a laxative screen. 2 branches, 2 very different differentials, and a practical tip. An extremely low or negative gap suggests stool contaminated with urine or water, which is a clue to surreptitious laxative or water ingestion. Let us put the categories side by side. Osmotic diarrhea is watery. Fecal fat is negative. The osmotic gap is high, and it improves with fasting. Secretory diarrhea is watery, often nocturnal and crampy. Fecal fat is negative. The gap is normal, and fasting changes nothing. Malabsorption and maldigestion are both fatty. Fecal fat is elevated. The gap is elevated, and both improve with fasting. Inflammatory diarrhea is defined by its markers: positive fecal white blood cells, calprotectin, lactoferrin, and occult blood. Functional diarrhea has a normal gap and improves with fasting. Read the table across. Fecal fat separates fatty from watery. The gap separates osmotic from secretory, and fasting confirms which one you have. Osmotic diarrhea starts with something in the lumen the gut cannot absorb. The classic culprits are poorly absorbed cations and anions, magnesium, sulfate, and phosphate, which are found in laxatives. Then poorly absorbed carbohydrates, mannitol and sorbitol, the sugar alcohols in sugar-free gum and candy, and lactose, in a patient who is lactose intolerant. The signature is that the diarrhea resolves when the offending substance is stopped. 2 laboratory clues confirm it: a high stool osmotic gap and a stool pH below 6, which happens when colonic bacteria ferment unabsorbed carbohydrate. And do not forget surreptitious laxative use. It is the reason a laxative screen sits on the osmotic branch of the algorithm. Lactose intolerance deserves its own moment because it is common and often missed. 2 teaching points. First, it is not only congenital, it can be acquired after an episode of gastroenteritis, after a medical illness, or after gastrointestinal surgery. So a patient can genuinely tolerate dairy for 40 years and then stop tolerating it. Second, the clinical picture is bloating, flatulence, abdominal discomfort, and diarrhea. Diagnosis is by hydrogen breath test, or simply by an empiric lactose-free diet. Treatment is a lactose-free diet, plus lactase tablets taken with dairy. And remember that lactose intolerance is an osmotic diarrhea. The unabsorbed lactose is exactly the solute holding water in the lumen. Secretory diarrhea has a profile you can recognize at the bedside. The stool is watery. The osmotic gap is normal. There is no change with fasting, and it is classically nocturnal with cramping. Mechanistically, the intestine secretes anions or potassium into the lumen, or sodium absorption is inhibited. Either way, electrolytes move into the lumen, and water follows them, increasing stool water. Notice why fasting does nothing. The driver is the epithelium itself, not the meal. That single question, does it stop when you stop eating, separates secretory from osmotic faster than any laboratory test. A practical bedside test. Have the patient fast and watch stool output. If it keeps coming through the night, this is a secretory process. Now the causes. The single most common cause of secretory diarrhea overall is infection, specifically bacterial toxins acting on the epithelium. In a patient with chronic symptoms, though, you have to go further down the list. Gastrointestinal neoplasms come next: carcinoma, lymphoma, and villus adenoma. The villus adenoma is the classic one to remember. A large secretory adenoma in the rectum or sigmoid can pour out potassium-rich fluid and cause a low serum potassium. So when secretory diarrhea comes with hypokalemia, put colonoscopy high on your list. Our patient did have a low potassium. And do not forget medications here either. Several secretory diarrheas are simply drug effects that resolve when the drug is stopped. The endocrine causes are a classic examination list. Addison disease, Vipoma, carcinoid, Zollinger-Ellison syndrome, mastocytosis, and hyperthyroidism, which works mainly by increasing motility. When you suspect one of these, check serum peptide levels, gastrin for Zollinger-Ellison syndrome, calcitonin for medullary thyroid carcinoma, and vasoactive intestinal peptide for Vipoma. Add a urinary histamine for mastocytosis. These are rare, so do not send the whole panel on every patient. Send them when the diarrhea is secretory, high volume, and the common causes have been excluded. And remember, carcinoid, flushing plus diarrhea plus right-sided heart disease is the classic triad, driven by serotonin. Now the diagnosis you must not miss: microscopic colitis. It is a common cause of chronic diarrhea of obscure origin, meaning the patient whose workup keeps coming back normal. It is most often seen in middle-aged women with autoimmune disorders. And there are three notable drug triggers: non-steroidal anti-inflammatory drugs, selective serotonin reuptake inhibitors, and proton pump inhibitors. Now go back to our patient. She is a 54-year-old woman with Hashimoto thyroiditis, taking naproxen, sertraline, and omeprazole. She matches this description almost perfectly. And it is worth saying plainly, this is not a rare disease. It accounts for a real share of chronic watery diarrhea in older adults, and it is profoundly underdiagnosed. Here is the single highest yield point in this whole lecture. The colon looks grossly normal on colonoscopy. Completely normal. If your endoscopist does not take biopsies, the diagnosis is missed. The diagnosis is made on histology. Biopsy shows lymphocytic and plasmacytic infiltration of the mucosa, with or without thickened submucosal collagen. That collagen band is what separates collagenous colitis from lymphocytic colitis. So the rule is simple. In chronic watery diarrhea with a normal-appearing colon, always take random biopsies from the right and the left colon. Practically, tell your endoscopist why you are sending the patient. A request that says rule out microscopic colitis gets you the biopsies. Chronic diarrhea alone may not. Treatment starts before any drug. Stop the offending medication if you can. The non-steroidal, the proton pump inhibitor, the serotonin reuptake inhibitor. Then budesonide is first-line therapy. It is a corticosteroid with high first-pass metabolism, so you get a local colonic effect with limited systemic exposure. Additional options are anti-diarrheal agents, cholestyramine, and bismuth subsalicylate. For refractory disease, consider anti-tumor necrosis factor agents. Most patients respond well, but relapse after stopping budesonide is common, so plan the follow-up. And do not stop at the prescription. Celiac disease is associated with microscopic colitis, so if symptoms persist despite budesonide, send celiac serologies. Bile acid-induced diarrhea is a mechanism worth understanding. Normally, bile acids are released into the small bowel to emulsify fat, and then almost all of them are reabsorbed in the terminal ileum. If the terminal ileum is resected or diseased, as in Crohn's disease, that reabsorption fails. The bile acids spill into the colon, where they act as irritants. They stimulate electrolyte and water secretion by the colonic mucosa, producing a secretory diarrhea. Treatment is an empiric trial of a bile acid binder. Cholestyramine is the standard choice. A clear response confirms the diagnosis. One nuance: with an extensive resection, the bile acid pool becomes depleted, and then binders make things worse, so resection length matters. A brief word on functional diarrhea and irritable bowel syndrome. It shares the secretory profile in one respect. The osmotic gap is normal. But unlike true secretory diarrhea, functional diarrhea decreases with fasting. And it should not wake the patient at night. And it should not cause weight loss. Those two red flags, nocturnal symptoms and weight loss, are exactly what pull a patient out of the functional category. Our patient has both, so irritable bowel syndrome does not explain her illness. We cover irritable bowel syndrome in depth in the dysmotility lecture. One more distinction. Irritable bowel syndrome is a diagnosis of positive criteria, not a leftover label for a workup that came back negative. Now we move to the fatty diarrheas, and the first is malabsorption. The defect is in the mucosa itself. The absorptive surface cannot take up nutrients. There are two ways that happens. You lose surface area, most often from surgical resection, or you have generalized mucosal disease. Celiac disease and inflammatory bowel disease are the examples. The clinical picture is bloating, foul-smelling stools, and floating stools, which together we call steatorrhea. Remember the laboratory profile: elevated fecal fat, an elevated osmotic gap, and improvement with fasting. And a clinical pearl: steatorrhea often shows up first as a stool that is hard to flush. Patients describe it long before you measure fecal fat. Celiac disease is the malabsorption diagnosis you will see most often. About 1% of the population is affected. In genetically predisposed patients, an immune reaction develops against gliadin, a component of gluten, which is a wheat protein. That reaction drives an inflammatory infiltrate into the small bowel mucosa. Look at the picture. On the left are normal villi, tall finger-like projections with an enormous surface area. On the right, the villi are blunted and flattened, the crypts are elongated, and lymphocytes fill the epithelium. Lose the villi, and you lose absorption. And celiac disease is common, so keep the threshold to test low, particularly in a patient with another autoimmune disease. Celiac disease often presents without much diarrhea at all, so learn the extra-intestinal clues. First, deficiency anemia from poor absorption of iron, folate, and vitamin B12. An iron deficiency anemia that does not respond to oral iron should make you think of celiac disease. Second, osteoporosis from impaired calcium and vitamin D absorption. Third, dermatitis herpetiformis, an intensely itchy blistering rash on the extensor surfaces. It is essentially celiac disease of the skin. And fourth, unexplained elevation of the liver enzymes alanine and aspartate aminotransferase. And the tie back to our patient. Autoimmune thyroid disease travels with celiac disease, which is exactly why we sent her serologies too. Diagnosis has one prerequisite that trips people up constantly. The patient must be eating gluten when tested. If they have already started a gluten-free diet, the serology and the biopsy can both turn negative. The first-line test is immunoglobulin, a tissue transglutaminase antibody, the most sensitive test. You can add immunoglobulin A, anti-deaminated gliadin peptide antibody, and immunoglobulin A, alpha-endomysial antibody. Duodenal biopsy confirms the diagnosis: blunted villi, crypt hyperplasia, inflammatory infiltrate. And absence of the HLA-DQ2 and DQ8 genes excludes it. So if a patient arrives already gluten-free and undiagnosed, you either check the genes or you ask them to eat gluten again before testing. Treatment is a strict gluten-free diet, and for most patients it works. But between 7 and 30% do not respond to the diet. When that happens, ask two questions. Is the diagnosis wrong, or is the patient not adherent? Non-adherence is far more common, usually hidden gluten, rather than deliberate lapses. About 5% have genuinely refractory symptoms. The complications to know are a risk of T-cell lymphoma and a risk of small bowel adenocarcinoma. Both are uncommon, but they are the reason we take celiac disease seriously even when symptoms are mild. And the diet is genuinely hard. Refer every patient to a dietitian. Adherence is the treatment. Whipple disease is rare, but classic. It is an infection with Tropharima whippli. It is systemic. So besides malabsorption, expect fever, lymphadenopathy, edema, arthritis, central nervous system changes, and gray-brown skin pigmentation. The pathognomonic finding is oculomasticatory myarrhythmia, rhythmic eye oscillations occurring together with contraction of the chewing muscles. Diagnosis is by biopsy and pathology, with immunohistochemistry and polymerase chain reaction. Treat with penicillin plus streptomycin, or a third-generation cephalosporin, for 10 to 14 days, then trimethoprim sulfamethoxazole for at least a year. Note why therapy runs so long. Central nervous system disease needs drug that crosses the blood-brain barrier. Small intestinal bacterial overgrowth means colonic-type bacteria colonize the small intestine. They deconjugate bile acids and consume nutrients, producing steatorrhea, vitamin B12 and iron deficiency, and protein-losing enteropathy. It associates with dysmotility, as in diabetic neuropathy and scleroderma, with altered anatomy, from Crohn's disease, surgery, or fistulae, and with immune deficiency, celiac disease, and cystic fibrosis. Diagnose with a hydrogen or carbon-14 xylose breath test or with empiric antibiotics. Treat with 7 to 10 days of rifaximin, metronidazole, or a fluoroquinolone. A caution: breath testing is imperfect, so empiric antibiotics with a clear response remain a common approach. Round out the malabsorption list with the causes that do not fit neatly elsewhere. First, short bowel syndrome after an extensive bowel resection. You simply do not have enough absorptive surface left. Second, chronic mesenteric ischemia, classically food fear and weight loss in a patient with vascular disease. Third, eosinophilic gastroenteritis. Fourth, intestinal lymphoma. Fifth, tropical sprue, which follows travel or residence in the tropics. And sixth, Giardia infection, a protozoal infection that is a genuinely treatable cause of chronic malabsorption. So always ask about camping and untreated water. Notice how many are found by history alone: travel, prior surgery, vascular disease, faster than any laboratory test. Maldigestion is the cousin of malabsorption, and people mix them up constantly. Here the mucosa is fine. The problem is upstream. Nutrients are never broken down into absorbable pieces. That is defective intraluminal hydrolysis, and it is usually due to pancreatic or hepatobiliary disease. The commonest cause is pancreatic insufficiency, most often from chronic pancreatitis or pancreatic cancer. Test with stool elastase, chymotrypsin levels, fecal fat, or simply an empiric trial of pancreatic enzyme replacement. A clear response to enzymes is itself diagnostic. And one contrast worth holding on to: in maldigestion the villi are normal. In malabsorption they are not. Same fatty stool, very different biopsy. The second maldigestion mechanism is too few bile acids. Without bile acids you cannot emulsify fat, so fat is never presented to the pancreatic enzymes properly. There are three routes: reduced synthesis, as in cirrhosis; cholestasis, as in primary biliary cholangitis; and loss of the pool after ileal resection, because reabsorption fails. Notice that ileal resection appears twice in this lecture. A limited problem spills bile acids into the colon and causes secretory diarrhea. A larger one depletes the pool and causes fat maldigestion. Test with empiric bile acid replacement therapy. And clinically, watch for the fat-soluble vitamin deficiencies that follow: vitamins A, D, E, and K, including a rising prothrombin time. Inflammatory diarrhea announces itself: positive fecal white blood cells, positive calprotectin and lactoferrin, positive fecal occult blood, plus fever and abdominal pain. The infectious causes are chronic Clostridioides difficile, Entomoeba histolytica, Yersinia, cytomegalovirus, and tuberculosis, especially in immunocompromised hosts. Cytomegalovirus and C. difficile are notorious for causing exacerbations of inflammatory bowel disease. Then inflammatory bowel disease itself: Crohn and ulcerative colitis, where fecal calprotectin is most useful for ruling disease out. Finally, radiation enteritis, ischemic colitis, and neoplasia. In an immunocompromised patient, look for cytomegalovirus on biopsy before escalating immunosuppression. Back to our patient. Her fecal fat was negative, so she stayed on the trunk. Her occult blood and calprotectin were normal, so she stayed on the trunk again. Her stool sodium was 65, and her stool potassium was 50. 2 times 115 is 230. 290 minus 230 gives an osmotic gap of 60. That is less than 100. So secretory, or functional. Nocturnal stools and weight loss, rule out functional. Imaging and hormone levels were normal. Colonoscopy looked completely normal, but the random biopsies showed lymphocytic colitis. We stopped the naproxen and the omeprazole, discussed the sertraline with her psychiatrist, and started budesonide. Her celiac serologies were negative. Let us collect the traps. First, a normal-looking colonoscopy does not exclude disease. Microscopic colitis is invisible to the eye, always biopsy. Second, nocturnal diarrhea and weight loss are organic until proven otherwise. Never label those as irritable bowel syndrome. Third, the medication list is a diagnosis waiting to be made: proton pump inhibitors, non-steroidal anti-inflammatory drugs, and serotonin reuptake inhibitors especially. Fourth, celiac testing requires the patient to still be eating gluten. And fifth, a low potassium with secretory diarrhea should send you hunting for a villus adenoma. And one more: never anchor on a single negative test. This workup is a sequence of gates, not one answer. Let us pull it together. Chronic diarrhea means more than 4 weeks, and there are 4 categories: watery, fatty, inflammatory, and functional or structural. Work the algorithm from the top. Check fecal fat. A positive result means malabsorption or maldigestion. Check inflammatory markers. A positive result means inflammatory disease. If both are negative, calculate the stool osmotic gap. Below 100 is secretory or functional. At or above 100 is osmotic. Then match your treatment to the mechanism you found. That is the whole topic in 5 steps. And carry the 2 red flags with you: nocturnal diarrhea and weight loss. They overrule any reassuring first impression. These are the sources behind this lecture. The General Evaluation of Chronic Diarrhea draws on the review in the Journal of the American Medical Association from 2016 and the American Gastroenterological Association Guideline in Gastroenterology from 2019. Celiac disease follows the Lancet Seminar from 2022. Whipple disease follows the Lancet Review from 2016. And microscopic colitis follows the Gastroenterology Guideline from 2016. Thank you for working through this one with me. I will see you on rounds. If you want the irritable bowel syndrome material, that lives in the dysmotility lecture in this same series.